right, and so welcome to step 4 of 12 lead EKG interpretation. So, what are we talking about in this section? Well, we're going to talk about pre-excitation, which is also known as re-entrant rhythms. And one of the more classic ones that a lot of people have heard of is Wolfe-Parkinson-White, which is abbreviated as WPW. And the idea is this. Why are we talking about it now? It's a 12 lead class. We're here for heart attacks and all the really cool stuff like that, right? Well, the thing about it is this. If your patient is having a re-entrant rhythm, it's very easy to miss that step. And, the bigger risk is that patients with re-entrant rhythms, it creates a change in the way the EKGs lays out. And those natural changes that occur with that can be mistaken as other things. Specifically, we're worried about ST changes that occur because you might think that it's ischemia, but in reality, it's due to the re-entrant rhythm. The other one to worry about, the ischemia. So you're thinking about maybe T-wave inversion or ST elevation or depression can occur. But that, again, is due to the re-entrant rhythm. The other thing is that you can get wide complexes in your QRS. And if your patient happens to be tachycardic, someone might think that that was V-tach, when in reality it's not. Or more simply, you might mistake that wide QRS for a bundle branch block, which it's not. It's really easy to identify, particularly with Parkinson-White, because you're looking for delta waves, which we'll talk about in a few more slides. And then symptomatics is always important. What is your patient's symptoms? These folks tend to have paroxysmal tachycardias, tachycardic for no reason. And so that can be anything from palpitations to syncope. And that may be what brings them into the hospital. Either way, those are kind of a quick overview of why we're doing this and what we're looking for. So what is Wolfe-Parkinson-White? Well, we evaluate that rhythm the same way we do any other one. And we're going to look for, if it's regular, what the rate is. I'm going to look at my P waves. I'm going to look at my PRI and my QRS. So is it going to be regular? Yes. What's my rate going to be? Anywhere from Brady to tachy. My P waves, they're going to be normal, upright, regular, that sort of thing. But what really holds value is your PRI and your QRS. And so Wolfe-Parkinson-White has short PRIs, less than 0.12. PRI. They will also have a wide QRS, larger than 0.12. And that'll make more sense as we go to the next slide. You'll also have something that's really unique, which is known as a delta wave. And that's a real telltale sign that makes this actually a lot easier to do than you might think. You will see some ST and T wave abnormalities because of the way the conduction works. It causes those to be reflected differently in the EKG. And again, symptomatics is huge. You can get a paroxysmal tachycardia just out of nowhere. One of those classic scenarios is that 7th grader who's playing basketball, who's running up and down the court and then just collapses all of a sudden. They come, they check, they can't find a pulse, they get the AED, they shock them, and that works great. It's kind of like a cardioversion. Essentially, it's a defibrillation technically, but it kicks them out of that tachycardia, gets them back to a slower rate, bring them into the hospital, and then it's the 12 lead where we manage to find that they have something like Wolfe-Parkinson-White or one of the other subtypes. So, again, syncope. All right, so a delta wave. I've mentioned it a few times. What the heck is it? Well, the delta wave itself actually is pretty simple. It's this nice gentle curve right here that's not supposed to be there. So let's measure this the same way we always do. So our P wave starts here and our P wave ends here. And in this scenario, that is going to be my PRI, because starting here is where my QRS goes up and down and back over to here. And so from here to here is my QRS. And so what happens is we've lost this section here, which is your PR segment that normally occurs. And then we've also lost that nice sharp upward deflection of our R wave. And what that does is then creates a situation where you have a short PRI that is less than 12 and a longer QRS that is greater than 0.12. And so you can see how the wider QRS is actually subtracted from the PRI to create short PRI, wide QRS. And that's how, people might mistake this for a bundle branch block. But again, it wasn't a nice sharp like this. This one has a gentle wave upward. All right, that's a delta wave. Oh, sorry, here we go. Okay. Delta wave. So how does it happen? What makes all of this occur in the first place? Well, for Wolfe-Parkinson-White, the bundle of Kent is the primary culprit for this. And this is the bundle of Kent over here. It's this little gap that exists way out here on the left ventricle. How does it work? Well, first off, we have to talk about valves. And valves are made of cartilage. And that is a great insulator. Sorry, I don't know why that line got in there. Cartilage just does not conduct electricity. It's a fantastic insulator. And if you didn't realize it, the valves, all four of them, actually lie across this exact same plane through here. So by having all four valves laid out that way, it completely separates the atria from the ventricles and insulates them so that none of that electrical conduction can pass through, except through the AV node. And that AV node then winds up being that only point of connection between the two. And it's actually really clever. And so I'm going to draw a picture here. It's not to scale. It's nowhere near perfect. But if you look down through the heart, and we say that these are your four valves, between all those chambers, you've got your AV node right here in the center. And that AV node then is that one point of conduction. Otherwise, the rest of this whole white section in between is insulation, keeping electricity from flowing through. If you remember, the endocardium is made of cartilage as well, so the inside of the heart doesn't allow conduction either, the deepest, most inner part. So how does that bundle of Kent work then? Or why does it wind up allowing a reentrant rhythm to occur? Well, the idea is this. A normal a normal heartbeat starts at the SA node, travels through, travels down, gets to the AV node, and then the AV node is the only point in which it can travel through down to the ventricles. It goes down through the ventricles up here, comes up, and normally it would stop right here because it hits the cartilage. But what winds up occurring is that because of that bundle of Kent, there's actually an opening between the ventricles and the atria that will then, that electrical conduction can pass through. If that, from the ventricles, winds up connecting with atrial cells that have repolarized and are ready to roll, you can then wind up using cell-to-cell conduction to work your way backwards across the atria, and then if it hits the AV node at just the right time, when it's repolarized and ready to fire again, you wind up popping through, and you've now taken a shortcut. You've re-entered. And what happens is that whole process can go over and over and over again. And if it decides to speed up, you'll wind up with a reentrant tachycardia or a paroxysmal tachycardia potentially as well. And so that's how the bundle of Kent works. That's how all reentrant rhythms usually work, is that for whatever reason that signal can loop back through. One of the really scary ones is going to be if it goes the other direction, so that you've got a normal beat coming from the SA node, and it travels its usual pathway, and for whatever reason it travels down and manages to catch the ventricles. And so now you have this beat traveling from completely the wrong direction. In fact, if things time out right, you could even travel retrograde. Retrograde through the AV node and back up and back around that way. And as you can imagine, that's pretty disorganized. In fact, these will wind up looking a lot like, because we're using that cell to cell, these will wind up looking a lot like a PVC, or if it's going fast enough, VTAC. So you have to watch out for that kind of thing too. Either way, we're going to be treating the symptoms. So, if they're tachycardic, if they're syncopal, all those different things that we may need to do. The definitive therapy for these is going to wind up being ablation, if it can be done, to destroy those cells, because scar tissue doesn't conduct electricity either. And so by destroying those aberrant pathways, that would then prevent this from happening again. All right, so let's take a look and practice what we've been learning. So step 1, rate. Step 2, rhythm. So our rate for this slide, and again, this is in your handout. There's some larger ones to be seen because I know it's difficult to see this on the screen sometimes. You are looking at, apologies. There we go. A rate of 90, and we're in sinus rhythm, as you can tell by your 2 lead down at the bottom. We're going to talk about our QRS, our mean QRS specifically, as step 3. And so we're going to look in our lead 1, which is positive, and our lead AVF, which is negative. So we have a positive and a negative, which gives us, and if you look at your handout, that's going to be a left axis deviation. Let's find our most isoelectric. And our most isoelectric, well, we've got positive, negative, negative, positive. So it looks like our AVF is the most isoelectric because it's the smallest, honestly. And so our ISO is AVF. So if we make our fun little dial and we say that our AVF is our isoelectric, which one's perpendicular to it? And that's going to be your lead 1. And since we're looking for a left axis deviation, that fits in this quadrant here. So we're going to go with mean QRS of, 0 degrees. And again, we're doing this so that we can be on the lookout for hemiblocks, left anterior hemiblock, things of that nature. All right, so finally, step 4. And for pre-excitation. All right. So what we'll start with the 2-lead because that's the most simple. And we're going to measure our PRI, and it's going to be from here to here or so. And that's really small. That's probably a 0.08, somewhere in that zone. And then we're also going to look at our QRS, which is probably on the order of 0.16. So pretty small, pretty big. And then most importantly, if you look closely, there's a nice big old delta wave right there. Fairly easy to spot that angle that it's going up at, right through there. And now you can actually check all your leads for this delta wave now that you're looking for it. And you can see that there's a gentle slope on this one. There's a pretty sharp slope through here. Pretty sharp here as well. And then you can even see it in the V leads as well. The final thing, so we'll say yes to this. And then I'm just going to make a side note and look for any kind of ST changes or T wave. And what we see is that we have an inverted T wave here. We have inverted T wave here. And these actually have some ST elevation in them. And you can see there's the T wave on this one. I'm going to scoot over a little bit. T wave is inverted. And what this is known as is a pseudo-infarct. And it's saying that this patient has a reentrant rhythm so that those T wave and ST changes may actually be due to that reentrant, not necessarily an ischemic event. All right, next one. All right, so number 1, rate, number 2, rhythm, and I apologize, there's no 2-lead on this strip, but we have a rate of right around 55 because you used the small box method to count those out. And then you also have a rhythm of sinus Brady. So we'll look for our mean QRS again. And then we'll see that this one is ever so slightly positive. And our lead 1 and our lead AVF is very positive. So that we have up and up, which equals normal quadrant. Which one of us is most isoelectric? And so we're really positive, negative, negative, positive. So the most isoelectric is going to be lead 1. So 1 lead. So if we spin out our dial here, we say that you are the most isoelectric, who's perpendicular. So if this is 1, then this is AVF, and AVF, and we're looking in the normal quadrant. So AVF leads us with a positive 90 degrees. Mean QRS. So our final part of this section is going to be looking for pre-excitation, which is step number 4. And so this, you can kind of look at it the other way. Let's look for delta waves. In looking through each of these, do we have anything that represents delta waves? And the answer is yes. Particularly here and here, we've got some pretty good looking delta waves, but we'll want to measure out our PRIs just the same. And we'll use the lead 3. And my PRI is probably right at 0.12. And I know it's difficult to see with this zoomed in as close as it is. And then so that's our PRI. And then our QRS from here to here is probably right at 0.12 as well. And so the short side of the PRI, the wider QRS, presence of what appears to be a delta wave, add in a little symptomatics. Like I said, if it's a kid or maybe they came in with, some tachycardias that, we didn't know why, syncope, whatever that may be. Those are reasons to, start suspecting that kind of stuff. So I'll go ahead and say yes to that. Last thing is we're going to look for our pseudo infarct. And where do we have that at? Well, we have an inverted T wave here, inverted T wave. Got an inverted T wave here, inverted T waves, and this actually has a great delta wave on here. And that would be about that. So we'll say yes to that as well. All right, there you have it. That is pre-excitation and how to find it using delta waves, PRI, and QRS. Next up is going to be step number 5, hypertrophy.